Hi, my name is Julia Bruno and I am a current freshman nursing student at the University of Michigan. Today I will be presenting a patient. Patient is a 19-year-old single Caucasian female. She is currently a full-time student at the University of Michigan. Her primary source of care is from a family practitioner in her hometown. Chief complaint, joint pain. History of present illness. Patient reports that she first began experiencing joint pain in 2012 when she developed Osgood-Schlatter disease in her both knees. Patient treated Osgood-Schlatter with ibuprofen, stretching, and limiting physical activity for 6 months. Patient reported that she then returned to physical activity. Patient first experienced pain in the hip in 2013 when she pulled her hip flexors while participating in Olympic-style weightlifting. Patient again treated this pain with ibuprofen and limited physical activity. She reports a reduction of pain in returning to sports after 2 months. Patient also experienced hardening of facet joints in her lower back due to Olympic-style weightlifting in 2012. Patient attended physical therapy once a week for 2 months to treat her hip flexors and continues to attend it in order to treat the pain in her back. Patient reports continued pain in her lower back during physical activity that she describes as a dull ache and rates it a 5 out of 10 at its worst and only during physical activity. Additionally, patient reports that her joint pains do not conflict with her daily activities and are only aggravated by physical activity. She continues to treat with ibuprofen, rest, and physical therapy once a week. Vitals. Patient presented with the following stable vitals: a temperature of 98.9 degrees Fahrenheit taken orally, a pulse rate of 86 beats per minute, a respiratory rate of 12 breaths per minute, and a blood pressure reading of 134/92. Patient reports no pain when resting. Health history, childhood, and chronic illnesses. In 2001, patient was diagnosed with asthma. Patient reports that she treats with an ProAir albuterol sulfate inhaler. She reports no serious or recent asthma attacks. In 2009, patient developed a severe sinus infection that required an MRI to diagnose. In 2012, patient developed small, benign ovarian cysts that ruptured. This required hospitalization for 3 days until diagnosis and continues to be treated with Yaz contraceptive pills. Patient developed similar ovarian cysts in 2013 that did not rupture or require hospitalization, continues to be treated with Yaz. Immunizations. Patient reports being up to date with all immunizations, the most current being the flu shot administered in fall of 2016. Allergies. Patient reports allergies to dogs, cats, grass, trees, and dust. The patient has no known drug allergies. Hospitalizations and surgeries. As previously mentioned, patient was hospitalized in 2012 for ovarian cysts for 3 days for diagnosis. In 2014, patient had her wisdom teeth removed and recovered at home. Patient experienced no other known hospitalizations or surgeries. Current medications. Patient is currently on 2 medications. Patient takes Yaz contraceptive pills each day upon waking up to prevent the development of future ovarian cysts. Patient also takes an albuterol inhaler twice before strenuous exercise and additionally when needed to treat her asthma. Functional assessment health habits. Patient reports no recreational drug use or smoking and occasional social drinking that she defines as approximately once a month and consumes 3 to 4 drinks when out. Patient exercises approximately 5 times a week and reports getting 6 to 8 hours of sleep a night. Patient reports attempting to maintain a healthy diet and primarily eats in dining halls and on campus. She consumes no red meat for personal reasons but has no other dietary restrictions. Patient consumes little to no caffeine and reports only drinking energy drinks before tests or when she finds it necessary to get a boost. Patient reports that she always uses a seatbelt and appropriately uses her medications and inhaler. Psychosocial data. Patient cites her home as Orange County in California and lives with her biological parents. She has an older brother and sister. Patient reports close relationships with all members of her family. Patient currently lives with a roommate in a dorm on campus and reports that she feels it is safe with few environmental hazards. Patient reports having a close friend group and a healthy relationships with her peers. She has lots of experience with various religions but does not feel drawn to one and participates in no spiritual practices. She does not report any specific cultural practices that she participates in. As a freshman in college, she is currently a literature, science, and arts major and considers her biggest stressor to be her education and time maintenance. Patient does not regularly go to the hospital. When she is at home, she receives any health care from her family practitioner. Family history. Patient reports a family history of depression and arthritis on her maternal side, with her great-grandmother, grandmother, and mother all having experienced them. She has no living grandparents, each she reports dying of a different type of cancer that she could not recall. She also reports a history of sarcoidosis in her mother and maternal grandmother. She reports no other prominent health histories from her family. Review of systems, system number 1, musculoskeletal. Due to the patient's complaint of joint pain primarily in the knees and hips, it is important to assess her musculoskeletal system. In addition to her history of Osgood-Schlatters disease and hardened facet joints in the back, the patient reports crepitus and pain in the jaw. Patient reports pain and crepitus in her knees and hips specifically. However, patient reports no swelling, redness, warmth, or deformities in these areas. She rates the pain at a 0 to 2 out of 10 when resting, and at its worst a 5 when doing physical activities. As previously mentioned, patient treats this pain with ibuprofen as needed and weekly physical therapy. Additionally, patient reports no limitations in her range of motion or any changes in her daily activities due to her joint pain. She experiences no weakness and currently does not have arthritis, though she does have a family history of arthritis primarily on her maternal side. Patient denies any other muscle problems such as traumas, disorders, or diseases, personal or familial. Physical assessment of system number 1, musculoskeletal. Patient presented appropriate muscle mass and bone structure for a person of her age and weight. Patient's gait was flowing and steady with erect posture. She had no difficulty walking. Patient's spine is midline with no deviations, and her shoulders, scapula, upper extremities, and iliac crests are all level and symmetrical bilaterally, indicating no signs of scoliosis. Patient has active and full range of motion in all tested joints, as well as full muscle strength, graded at a 5, indicating that she was able to meet my strength with all tested muscles bilaterally. No erythema, inflammation, or warmth was present or palpable at any joints. However, crepitus was present with movement in the TMJ, hips, and knees. Furthermore, she indicated pain at the hips and knees during hip abduction and adduction and flexion at the knee. No other pain or crepitus was present elsewhere. Review of systems, system number 2, respiratory. Due to the patient's history of asthma, the respiratory system is a prominent body system to assess. Patient reports rare shortness of breath, usually accompanying an asthma attack. She has no history of pneumonia or bronchitis. Patient reports no cough, thus no sputum production. She also denies a history of frequent upper respiratory infections. In regards to her asthma, as previously mentioned, she was diagnosed in 2001 and reports infrequent asthma attacks, with the last one being sometime in high school. When asthma attacks do occur, she describes tightness of her chest with shortness of breath and pain and wheezing as she tries to breathe. In order to prevent these attacks, she takes her inhaler twice before exercise and whenever she is feeling short of breath. Patient reports this as having no effect on her daily activities and feels she can physically do everything that she wants. She has no family history of respiratory problems. Patient denies any other respiratory problems such as traumas, disorders, or diseases, personal or familial. Physical assessment of system number 2, respiratory. Patient presented with a thorax of the appropriate coloring for her ethnicity, pink undertones, and no injuries or deformities. Her chest was symmetrical with her AP transverse diameter creating a ratio of 1 to 2, which indicates no signs of barrel chest. Additionally, her breathing was even and steady, with no deep or shallow breaths, indicating no signs of respiratory distress. Her trachea is midline and her back rose and expanded symmetrically as expected when palpated for posterior expansion. Additionally, tactile ephremitis was present posteriorly and felt bilaterally with no hyperactivity or unexpected findings. Her ribs and thorax were palpable and symmetrical with no signs of injury or deformity. No crackles or rhonchi were heard anteriorly, laterally, or posteriorly with auscultation. However, soft, high-pitched wheezing was identified at the base of the lungs anteriorly and posteriorly in the lower back. Otherwise, appropriate bronchial, tracheal, vesicular, and bronchivesicular sounds were heard throughout the lung fields in the thorax. She showed no signs for consolidation in the lungs. When tested for bronchophony, her uttered 99s were muffled, as were her E's when being tested for egophony. Finally, when she was tested for whispered pectoriloquy, the 1, 2, 3s that were uttered were inaudible, as expected, again indicating no consolidation in the chest. Pertinent system number 1, cardiovascular. According to a peer-reviewed journal article by Mario Cazzola titled Comorbidities of Asthma, Current Knowledge and Future Research Needs, asthma is often associated with a variety of comorbidities. In fact, the article states that it has been found that asthmatic individuals had at least 50% more comorbidity. Because cardiovascular disease is a common comorbidity of asthma, it is critical to perform a cardiovascular assessment. By assessing the cardiovascular system regularly, it ensures that any potential cardiovascular disease that the patient may develop will be identified early on. Pertinent system number 2, neurological. Additionally, according to Haran Tharbo, author of the journal article Psychological Therapies for Anxiety and Depression in Children and Adolescents with Long-Term Physical Conditions, Children and Young Adults with Long-Term Conditions that are at a high risk for developing anxiety or depression. Considering that the patient has a strong family history of depression, a neurological assessment is a key assessment to perform. Furthermore, she asserts that specific risk factors for developing anxiety as a comorbidity include both youth and female gender. Therefore, a neurological assessment is a critical concern for the patient in order to ensure that she does not develop anxiety or depression due to her long-term condition. This is the end of my presentation of my patient. Thank you for watching.